So this is always an interesting one to do first thing in the morning, talking about suicide risk assessment and management in primary care. And I hope for anybody that is maybe still a little bit sleepy that this, with bringing some more alertness and attention to something that is personal to all of us. When I get into talking about the prevalence, it will be very clear that suicide impacts us in some way personally and pretty regularly in the role of primary care or pediatric work. And these are pictures from local media coverage in our state, as well as a picture of the Aurora Bridge, which for a long time was known as the Suicide Bridge in Seattle, and is the site of a patient I've worked with, her plan, and a couple attempts, and I'm going to talk about her in a little bit. So my goals for today is to briefly kind of couch the importance of this work in the data that exists, and specifically in our state. Understanding and underscoring the role of screening in primary care, and hopefully the bulk of the time spent helping to develop some increased confidence that you have the tools and resources at hand to do this effectively within the constraints of your busy days in primary care. So looking at epidemiology, we know that there is an estimated over 1 million suicide attempts in children and adolescents every year, which is a pretty alarming number. There's a lot more attempts than there are completed suicides, with about 1 completed suicide for every 100 to 200 attempts among youth. It is the second leading cause of death for 10 to 24-year-olds in our state, and that actually goes up to age 34, with about 2.6 completed suicides per week in our state. Every 2 years, Washington State does the Healthy Youth Survey. This is the most recent data that I could access. What we know from this data, wrong button, is that we have over a third of our youth, grades 8 up to 12, who report that they have had at least a 2-week period of being so sad or hopeless that they stopped engaging in activities as usual. Among this same surveyed group, we have 1 in 5 youth who have considered attempting suicide in the past single year. We have 15 to 18% who have made a plan in that last year, and 1 in 10 of our youth surveyed that have attempted at least once, sometimes multiple times, in the last 12 months. Also alarming is that is this trend right here. We have seen a startling increase in the rates of suicide among youth from 2016 to 2017, with a 32% increase among 10 to 17-year-olds and a 25% increase among young adults under age 25. It's not well understood why it is. Seattle Children's Hospital issued a press release when 13 Reasons came out, and they talked a lot about the contagion effect, and so that's certainly one of the theories here. Looking at population factors, we know that male youth are more likely to complete suicides, though it's females who have a higher prevalence of attempts as well as non-suicidal self-injury. The most common method of a completed suicide is firearms, with males accounting for about 52% of deaths by suicide due to firearm. Among females, they are more likely to use hanging and suffocation, with still the average being firearms being the number one. And in terms of ethnicity, we have the highest number of completed suicides among Caucasian youth, and when we're looking proportionally, we have the highest rates among Native Americans. So we know that this is an issue that we need to address, and how do we do that? In the largest study that exists to date that has looked at completed suicides, this was across 8 states and 8 different healthcare systems. They looked at 6,000 completed suicides across the lifespan. I think 7 or 8% of the total N was individuals 19 and below. And what they found is that primary care is the front lines. Nearly 50% of individuals who completed suicide came into contact with primary care in the single month prior to completed suicide, and 83% in the 12 months prior. Compare that to where we might think that patients would go. 19% appeared in specialty mental health in some capacity. Also interesting is that when we look at that 1 month prior or 12 months prior, we're not catching mental health diagnoses. So among youth in particular, it's estimated that 90% of youth who complete suicide have a mental health condition, usually depression, anxiety, or a bipolar disorder. And somehow it's not being documented or it's not being identified in those medical visits. So what is our role? They are coming to us. One of the most important things that we can do is early identification. And screening is, universal screening, is the means in which we likely can most effectively do this. It's also well known that youth and parents or guardians are really unlikely to disclose depression and suicidal thoughts or behaviors without being asked directly. So a screening tool that is used every time helps ensure that this question is being asked. Risk is also fluid. In some individuals, a risk for suicide escalates from thoughts about death to a plan and intent and access to means over the course of years. Sometimes that happens over the course of minutes. So again, catching catching what we can through universal screening helps. And this is consistent with the recommendations by so many professional bodies, the American Academy of Pediatrics, the U.S. Preventative Task Force, as well as the Joint Commission. So we now have federal guidelines coming down for large healthcare systems with guidelines for the management and prevention of suicide. And this is something that Swedish is undertaking and rolling out called Zero Suicide. You'll be hearing more about that coming soon. So what are the standardized tools and what's the evidence? What you're probably familiar with, very familiar with, intimately familiar with, is the PHQ, either the 9 or the A. They are both validated measures for 12 and up. And I like to just highlight that with regards to question 9 on these measures, it is the one time we can ask a single question about a life-threatening condition and get a pretty strong identification of level of risk. There are not a lot of other medical conditions where we have that same concise ability. And in fact, question 9 is as good of a predictor of a suicide attempt as cholesterol scores are of a heart attack. Now, if we are administering this and we are giving this regularly to patients, it means we have to review the forms. There was an interesting research study done that showed that only 17% of those patients or parents that completed this form endorsed some level of risk on question 9 that actually verbally disclosed to their provider that they were dealing with this. So make sure you have a good workflow around how you're checking patients' responses. I've listed out the PHQ as a universal screening measure, meaning that it catches a wide net. This is helpful for that big range of risk. Within that, we have targeted measures that help us to better tease out factors within that smaller risk subset that can help us identify proper management, treatment, and consistency in evaluation over time. What Swedish is employing is the Columbia Suicide Severity Rating Scale. And this is a 7-item measure. It has actually been validated for ages 5 and above. So you can use this widely with your pediatric population. And this is the evidence-based measure that has the most support and is the most widely used across healthcare systems. And while no measure is perfect, I've highlighted this throughout kind of the remaining clinical assessment pieces to help give you a guide and a format to the components of a risk assessment that are important to assess for. Acknowledging that this is a helpful guide and it's right there available for you in Epic. So for many of us, thinking through the clinical assessment piece and how we talk with our patients and our family about this is usually where some of the worries tend to come in. So I just want to provide a reminder that perhaps one of the most important things that you can do when this comes up is to just take a moment, take a breath, and don't panic. Uh, this is something that is commonly endorsed as a risk, and we know that most youth, even those with severe thoughts, are unlikely to complete a suicide. So you can slow down, you can be present, you can take a non-judgmental approach for anyone presenting with some suicidal beliefs, ideation, plan. In their lived experience, they have reasons that make sense to them for not living. And likely they have some reasons that make sense to them for living. So taking that non-judgmental approach allows you the opportunity to explore that with your patient. Oftentimes, parents and sometimes providers are worried that conversations about this can increase risk for suicide, and there's no data, no evidence that says that's the case, and in fact, to the contrary, talking about this helps destigmatize this, helps patients feel like they have a place where they can turn, and helps to provide hope. You might also have the case where a patient endorses extreme scores on all the other aspects of the PHQ, or maybe you've given the GAD, and they're not endorsing anything on question 9, on that question of suicidality. And I would encourage you to just to keep an open door with these patients, to let them know that if anything ever changes, that they can come and talk to you, as opposed to a closed statement like, okay, I didn't think so. Okay. So moving into how we navigate the conversation with patients, I first want to call out that risk assessment is not absolute. So we don't have any clear, validated, predictive models that say, yes, absolutely, this patient is low risk, or yes, absolutely, this patient is high risk, and there's this, this is what we need to do for them, which does leave a lot of gray and a lot of room for clinical judgment. The standardized tools are really helpful in making sure that we are using a consistent method of assessment. It also allows you to do this assessment efficiently, gives you some of the confidence that you're asking the most important questions. And I love that it helps facilitate documentation, which can be challenging at the end of a pretty draining visit. So in the conversation piece with a patient, and when we're talking about youth, I know that there are a multitude of scenarios in which this comes up in our clinics. Sometimes youth are there by themselves. Sometimes their parent insists that they are in the room with them. There is a lot of information that you can gather through observing the family dynamics and interaction, from the parent or guardian beliefs and attitudes around death, suicide risk, other risk factors. And it can also be really important to make sure it is standard practice to have a conversation with the child or adolescent individually, so that they can tell you what their experiences are. And the key things that I know that you're doing pretty efficiently in a visit are looking for what are the immediate warning signs, what are the risk factors, what are the protective factors. The same thing you do with risk for heart attack, for example. We're looking at the intensity and duration of the suicidal thoughts, the patient's intent, if they have a plan and access to that, and if they've engaged in any preparatory behaviors or previous attempts, so that you can use clinical judgment in addition to the tool to determine what I am calling an imperfect categorization of risk. I wanted to highlight that while, depending on what research you are looking at, you can find up to 100, 150 potential different risk factors for suicide, which makes tricky our evaluation. The one risk factor that is above and beyond in terms of its predictive value and being most robust is a history of past suicide attempts. So a patient, and this is across the lifespan, a patient who has attempted suicide in the past has 38 times more risk for a completed suicide in the future. The risk is the highest immediately following an attempt, particularly if the response to survival was one of regret or despair or feeling like they failed. And specifically 12 to 25% of individuals who attempt suicide within the last year will attempt again. So with regards to the other risk factors, I just want to highlight that in family practice settings, likely you already know an awful lot about this patient and family. You have a lot of knowledge already of risk factors, of protective factors and strengths. So some of the things that you might key in on is if there's any precipitants that help clue you to degree of risk right now. So have there been any recent stressors, events, losses that contribute to a negative emotional state? Another key risk factor is degree of social isolation and whether that youth endorses having support that they can turn to or not. And getting more attention is that exposure to suicide. So if there has been a suicide in their school recently, or they were exposed to it through media, for example. And just to clue you into considering how recent or distant these events were and the degree of impact that has. And to aid you in thinking about the interventions for this patient, considering which of these factors you're identifying are modifiable, right? So if you are seeing that the patient is depressed, then you have some ideas about treatment for depression, or if they are distressed because, and thinking about death because they failed their math test, thinking about how you would elicit support for tutoring or other resources at school versus unmodifiable factors, which might be family structure or dynamic, or it might be the size of their nose. With regards to protective factors, these don't do a whole lot in terms of changing the evaluation of risk, but it does do a lot to help us with identifying what interventions and where we can add in some things to help modify the risk. So helping to connect a patient to what their reasons are for living connects them to a positive association, a positive valence. And I've listed out some of the common protective factors to be mindful of. I'm not going to go over this in too much detail, but you have it as a resource available to you to just tie on to Dr. Quinn's presentation. What we do know is with involvement in bullying, that this does increase risk for suicide, and where we see the most risk is, and I'll try to get the language right, the individuals that are in both roles of being the recipient of bullying behaviors as well as the giver of bullying. Okay. Direct warning signs are important to look out for. In individuals that have completed suicide, 4 out of 5 teens have given clear warning signs. And these are the 3 that stand out in the literature as usually at least one of the 3 of these is going to be present when we are looking at a completed youth suicide. So making suicide threats, this can be through social media, this can be to their friend groups, it can be to a family member. It can be preparations for suicide, such as seeking access to firearms or other means, or researching this online, saying goodbye to friends and family members, as well as preoccupation with death and suicide. So it might be through essays or writing or through artwork, etc. This is a direct connection back to the Columbia Suicide Severity Rating Scale, and the manner in which they have sort of risk stratified or defined the risk buckets from low, medium, high. This is something that you can use directly as a part of your narrative with a patient, and you have the ability to obtain more information from them in the process. I want to highlight that endorsement of anything here, even if they don't go beyond, still with use of this measure, risk stratifies into a high risk category. And I'm going to talk about that in a little bit with regards to how we then come up with appropriate interventions for patients that may exist here all the way down to they have prepared, they have access, and they've engaged in preparatory behaviors recently. So the risk assessment piece, the standardized measures, and your narrative with a patient does lead to prevention and to interventions that have evidence base behind them. And this is my personal preference for how I think about risk stratification, which is that those individuals who may kind of seem like they encompass this high risk bucket are those that are in need of some kind of immediate intervention. at the medium level, that they're at increased risk of suicide in the future, and in need of a clinical intervention. And low risk, that their risk is not currently clinically elevated, and they may still benefit from an intervention. So in terms of interventions, I've lumped low and moderate risk together for the purpose of presentation, and to illustrate that what we are doing with patients, and I've bolded the ones that you are going to see on the next slide for high risk. These are really similar. When we are not thinking that a patient is needing a clinical intervention right then, immediately, we have the ability to refer to in-office behavioral health, if that is a resource that exists in your clinic, or helping the patient or patient and family with connection to referrals to mental health resources in the community. And then a crisis response plan. And I use crisis response plan as opposed to a safety plan for its versatility, so that anytime a crisis comes up and there's distressing thoughts or emotions that are difficult to handle, this is kind of the same aid that a youth can use. And the key components of this, and I having practiced this, is a tool that can be done relatively fast with a patient, particularly if you already have your SMART phrase developed and you're just filling in the details. And I have in the handouts, this is available to you. And you can fill in a lot of it in advance. So it's a collaborative effort with the patient to first identify what are the initial warning signs that there's a crisis. And this could be a thought that they're having. It might be the thought that I wish I could go to bed and not wake up. It could be that their behaviors are changing. When I'm not sleeping well, or when I don't want to get out of bed, or when I stop texting my friends back, that these could be their warning signs. It could be sensations that they're feeling. And so you'll want to capture that and just document that in their plan. And then coping tools describes anything that they can do to help with cooling down that emotion, even if it's just temporarily. And it refers to their internal skills, so activities that they can do independently in this case. So maybe you have a patient who really likes art, so doing some kind of artwork can be a part of their coping tool. Or they love math, and so doing some math activities is a calming thing for them. It might be listening to music, it might be journaling, it might be doing a puzzle, it might be petting their dog. The second one is the external coping. It's the people that they can reach out to, the places that they can go that are safe, that are helpful distractions. And it doesn't mean that they have to talk about what the nature of the crisis is for them. So it may just be that they call their best friend Sally, or that they go sit in their favorite chair outside. then we also do want to identify who it is that they trust, that they can talk to, and they can confide in. Ideally, we want one of those individuals to be a trusted adult that they can confide in. And then list out the professional resources where they can turn, including crisis line or text line. And then one reason for living. And I'm going to flip forward for a moment. Although this isn't the template that I use, I have demonstrated it like this to show that this is something that you can type up pretty quickly for a patient in a visit, and includes each of those components. What their warning signs are, what internal coping resources they have, external resources, who they can turn to confide in, and professional resources. And then what to do if they've tried all of these things and they are still not feeling safe. Tying back to the data on completed suicides and the method, one of the most important conversations that we can have that can truly impact the completion suicide rate is safe firearm storage. So this is one of those things that you can just have as a smart phrase ready and available to print, have a quick discussion with family about, and make sure, especially if you know of a specific plan, that the means are addressed by that household and anywhere else that that youth might go. Providing crisis resources, also something really easy and fast, and having a youth put them in their wallet or directly into their phone means that they are going to be more accessible when they are needed. We always want to have a plan for follow-up, knowing the fluidity, and that this is something that a lot of the times we do end up managing in primary care. And then this is new and wonderful research that I love is a caring contact message. And what a caring contact message is just a non-demanding expression of support. It can be in writing in an after-visit summary, and might include a message of hope, a message about the patient's strength, and a message that you care, look forward to, and are committed to seeing them again. As simple as including these statements here in your note to them, or in a follow-up phone call or a follow-up message. The data on this, the idea of a caring contact has come about through surveying individuals who have attempted suicide and are survivors. And they have said that these statements and these categories make a difference. The data also suggests that this lowers the rate of completed suicides. Okay, so in the case of those high-risk situations, we have a really tricky role in primary care with regards to these high-risk patients and determining, using our best clinical judgment, the most ideal intervention and plan. A lot of resources will say, go directly to the nearest emergency department. And it misses some of those nuances then of the fact that a patient may have engaged in some preparation or attempt 3 months ago, and now they're engaged with a therapist, and they're improving, but they are still struggling with some suicidal thoughts. It misses some components like the amount of family support and structure that may be available to that patient. So some questions that you may ask to help with determining, okay, is this emergent and they need emergent assessment at the ED, are evaluating, asking yourself, do I feel comfortable sending this patient home right now or not? And if your answer to that is no, and you don't have other clinical interventions that can provide some more comfort around that, then you have your answer, determining a way to get the patient safely to the nearest emergency department, where the experts in evaluating for this and coming up with protective measures can do their job. And another question to ask is if there are other accessible and really like immediately accessible lower levels of care that can meet that patient's needs. We have a tough time in our area because we have a shortage of resources. But it may be the case that this family has already been enacting efforts to get set up. So making sure that you're exploring what those are. And then you see all of the same items here. The additional piece I want to go over is enlistment of support. So one really good preventative thing that we can do is when we've identified who they trust, making sure that we're talking about one, confidentiality and limitations of, and taking that opportunity to get verbal or written consent to work with that trusted support person when it is a matter of their safety. I also have in your handouts a form that you can use for the support person, which walks through what they can do to support their loved one in a time of crisis, including some things to keep in mind with safety proofing of the home, like removal of firearms, but also removal of whatever means are that the patient identifies, removal of sharps, poisons, medications that can be dangerous if overdosed, including supplements. And to tie into that, the nuances of decision making around emergency department or not, if you're uncertain, you can use the behavioral health consult line. This is when it is not crystal clear that they need to be going to the ED right away. You can call our behavioral health team to get a consult on some of the factors that you might want to think through to help make that determination. I am nearly done, and I think I'm at time. So with getting your patient safely to the ED, make sure you're thinking through what the plan is. If you are sending a patient with friends, family, guardians, make sure that you have a thorough discussion and plan for if the situation changes, and conversations about things like where they're going to sit in the car and maybe employment of child safety locks in the car. And that if anything changes, calling 911 is the appropriate action. I've got some guidance here of how you might talk to a patient about that evaluation in the emergency department. And then a reminder of the importance of follow-up. If a patient has attempted suicide or they're high risk, the The time that is most important to follow up with them in is the 1 to 2 weeks following. And to kind of wrap it all up, I want to acknowledge the realities that we're faced with. That we're faced with being the frontline providers in a healthcare system that is under-resourced for our patients. We have really great evidence-based treatment that exists for suicidal behaviors, and it's really expensive, and there's usually not access, and so it's not available to most of the patients that we serve. On top of that, we have a shortage of outpatient mental health providers, and we have an even greater shortage of inpatient beds available, particularly among our youth. So I want to provide that reminder that even small interventions, the caring contacts, the making sure that you are providing the crisis resources and discussing safe firearm storage, leads to reductions in suicide and are interventions that you can do in primary care. And I'll leave it there. Make sure you have support for yourself, and I'm really glad that there is time for questions and answers.